I think I am the odd man out here among the speakers this afternoon during this session, being a pediatrician. So I'm going to talk to you on the recent advances in the management of cystic fibrosis. Now, before I get to the talk, I just need to highlight what we are dealing with here. When I came to UAE about 6 years back, I wasn't certain how many CF patients I was going to see. As you all know, being a Caucasian illness, my feeling was that I won't be dealing with that many CF patients. But soon, my outlook changed when I started seeing many CFs in my clinic. So I just want to give you a background of demographics we are dealing with here. So if we take the total population of UAE as 10 million, and let's say 20% is the local population, so we are dealing with local population of 2 million. It's virtually impossible to work out the incidence of CF among the non-nationals. As we know, 130 plus nationalities, floating population. So we'll ignore the non-nationals for time being and concentrate on the national population. So I think the incidence of CF among the national population is about 1 in 7,500. There aren't that many studies which look for the incidence of CF among Emirati population. And the only one study which was done almost 15 years back, they came out with a figure of 1 in 15,000 based on the genetic prevalence of CFTR mutation in a group of 1,000 randomly chosen people. So if you say the incidence is 1 in 7,500, there should be about 250 CF patients among national population of UAE. Of this 250, in the last 6 years, almost 60 patients have gone through the pediatric pulmonology service in SKMC. As they become older, when they turn 16 to 18 years of age, we transfer the service to Cleveland Clinic. So between 4 of us pediatric pulmonologists in SKMC, we have seen almost 60 patients in the last 6 years. So I'm talking to you mainly on my experience I gained by treating CF here in SKMC rather than my experience in UK. The other important thing which we need to highlight is the main change which happened in diagnosing CF in the last couple of years. When we look at the data of the age of diagnosis of CF in our clinic, it used to be about 8 years. That's the average age of diagnosis of CF in our pediatric population. But fortunately, in the last 2 years, we have started screening for CF in newborns now. So basically, since we started screening for CF almost 2 years back, we have diagnosed almost 10 babies. They have been picked up immediately after birth. So a lot of things have changed even from diagnosis in CF population. So I will go through this in more detail as I go through my talk. So I don't need to go through the etiology of CF. You all know what the issue is: chromosome 7, CFTR, protein synthesis, sodium chloride channel. That's just basic, just to show you that slide. So, as I said, we are dealing with about 200-250 CF patients among the national population. Now, so as I said, the CF screening has been there for almost 2 years now. What we normally do, when the baby is born, by day 2, we check the immune-reactive trypsinogen. And if the IRT, immune-reactive trypsinogen, is about a certain cutoff, we repeat the IRT again within the first 2 weeks. So if the IRT is raised on day 2 to day 5 and at the second week of life, then we refer these patients to one of the main pediatric pulmonology centers, i.e. SKMC or Tawam Hospital, where we perform the sweat test. And if sweat test is raised, then we send the baby's blood sample for CF mutation analysis. So that's the diagnostic pathway we have implemented for screening in CF. Now, this has made a lot of difference because, as you all know, if you pick up the CF early in life, we can make big difference in the management of our children. The main difficulty we used to have previously was that by the time we diagnose CF patients, they usually come to us either with failure to thrive, recurrent chest infection, abdominal complication. By the time we diagnose them, these babies would have suffered significant bronchiectasis, and it's virtually impossible to reverse these changes. So with screening now, we are able to pick up the babies at birth, and that's going to make big difference in the So when I moved from Manchester to Abu Dhabi in 2015, we had data for almost 5 years of national screening program in UK. And we could see the difference these babies had after we implemented screening. The main difference we noticed was significant weight gain, significant reduction in the number of chest infections these babies suffered because they were diagnosed early, put on appropriate treatment early in life. So my point I'm trying to highlight is that newborn screening in CF has made big difference in the management, overall management of CF. And I'm highlighting this because I know most of the audience are adult pulmonologists, but you have to appreciate how much this has, how much difference this has made in the management of our CF patients. Now, as you all know, the basic treatment of CF until recently has been pulmonary toileting by bronchodilators, hypertonic saline dornase, physiotherapy, etc. In pediatrics, what we normally do, by the time we diagnose these patients, we normally start them on antibiotic prophylaxis. There has been a lot of controversies on putting CF patients on prophylactic antibiotic at the time of diagnosis. Now, where I worked in Manchester, I had a professor called Professor Tim David, who used to be one of the most senior-most professors who dealt with CF. He used to put all children diagnosed with CF from birth to up until 16 years of life on daily fluclox antibiotic prophylaxis. He was widely criticized for this management, but he used to do it. He has been doing it for almost 15 years. Now, when CF port database was introduced in UK, we could put the data from each and every pulmonology the CF center into national database. When they looked at the data, what they found was that in our center, where we put babies on a prophylactic fluclox antibiotics from birth, the lung function was slightly higher compared to other centers. So there was a case in putting antibiotic prophylaxis from birth. But unfortunately, the incidence of Pseudomonas aeruginosa isolation in our center was slightly higher compared to other centers. So the point against putting these babies on daily fluclox antibiotic prophylaxis was that this will increase the chance of these babies colonizing Pseudomonas aeruginosa early in their life. But at the same time, the lung function of our pediatric CF population compared to the national centers were higher. We had the second or third best lung function among all the centers in the country, but the Pseudomonas carrier rate was probably the third highest in the country. So if you look at the North American management of CF, they don't put fluclox prophylaxis for their babies. They usually stop the fluclox antibiotic prophylaxis by about 3 or 4 years of age. So then in UK, they are currently doing a clinical trial comparing the babies who are put on fluclox antibiotic prophylaxis from birth versus babies who don't have any antibiotic prophylaxis. And the trial is nearing completion. The initial data shows that perhaps there is a case of putting fluclox antibiotic prophylaxis up until 3 years of life. So to cut the story short, in our center, we start all newly diagnosed CF on fluclox antibiotic prophylaxis, and we continue this management 3 years of life. So the management includes antibiotic prophylaxis, pulmonary toileting, and obviously creon and vitamin. That's the mainstay of management, and that has been the mainstay of management up until 12 years ago. So 12 years ago, and if you wind the clock back a bit, there have been a lot of research being done on CF gene therapy. And I was a trainee at that time when this trial was going on. And I have seen these patients coming to Oxford for this trial, and they tried a lot of things, but unfortunately nothing worked out. The main issue in the CF gene therapy has been that they used to introduce this through a vector into the lung, and the vector they use is adenovirus, which unfortunately caused a lot of inflammation in the lung tissue, and that's where that trial actually never took off or had any desired effect like we anticipated. And then about 13 years back, the CFTR modulators came into the market. So let's see what CFTR modulators are. In simple terms, we know that CFTR protein is synthesized, it is trafficked, and it reaches the cell surface, which helps in the normal function of sodium chloride channel. So the idea is that you're reversing the cause of illness here. So the CFTR modulators, which is a class of drug which came to the market almost 12 years back, which has been the life-changing drug for the CF patients. Basically, it works in two ways. Number one, by increasing the number of CFTR receptors at the cell surface, and number two, increasing the quality of this, the protein. So there are two ways by which it works. So I'm just going to go through this slides quickly. So the first group of CFTR modulator which came into the market, what's called is ivacaftor. And as I said, this has been in the market for almost 12 years now. This ivacaftor or Caldolor, this is licensed for only 9 CFTR mutations. Remember, there are almost 2,000 different CFTR mutations which is identified now. Among these 2,000, this ivacaftor or the Caldolor, which came out to the market first, is only licensed for the 9 common CFTR mutation. Fortunately for the UAE population, the most common mutation called S549R was one of the licensed mutation to which this ivacaftor was effective. Compare this to the Caucasian population. The most common gene among the Caucasian population which was eligible for the CFTR mutation was G551D, which accounts only for less than 2% of the population. For example, there are 10,500 CF patients. Of the 10,500 CF patients, almost half of them have delta 508, which is the most common mutation. Only 450 patients had G551D. So in a big country like UK, only 500 patients were eligible for CFTR mutation, whereas in UAE, such a small country with less number of CF patients, almost 60% of CF patients were eligible for this CFTR modulator. So UAE was one of the first countries who benefited from this group of drugs when it came out to the market initially. This came out about 12 years back. Now I'll go through those details in a minute. Now I would take you back almost 15 years back, how our life has changed when CFTR modulators came to the market. You know, when I started my consultant job, I used to get called in almost daily to hospital because we had so many sick CF patients in the pediatric age group. I looked after almost 370 CF patients in Manchester Surgery Center, and every day I used to have at least 2 or 3 sick children who are waiting for a lung, who is in the transplant waiting list, and they used to come with hemoptysis, worsening of respiratory symptoms, etc., you name it, pneumothorax. So we were in hospital almost every night. From that stage, when CFTR modulators has been extensively used, we never used to have any sick CF patients in the pediatric age group. So as a pediatric pulmonologist, our life has changed significantly, especially for CF clinicians. Life has changed significantly since we started using the CFTR modulators. And the first one was ivacaftor, and our patients in UAE benefited significantly from this drug. Let's go through this drug in detail. Keeping all this just a bit more. So when the initial trial was done, this ivacaftor showed an improvement of lung function FEV1 of 9% in the patients who took ivacaftor. They also showed significant reduction in the frequency of chest infection in the trial population. But once we started using this drug, almost all the clinicians across the world unanimously said the improvement in lung function is definitely more than 9%. It's one of the rare instances where the actual effect among the patients are much better than what we actually saw in the trial. So I had a patient who was on the waiting list for lung transplant. 12-year-old girl. She has been on a transplant list for almost 2 years, and a bedridden, oxygen dependent on CPAP. And then I got this drug on her even before this drug was approved by NICE in UK. She was the first patient to get this drug in UK. And within 3 months, she came off oxygen, she came off BiPAP, and she could walk independently. Her lung function from 16% improved to about 42% within 3 months. And she maintained the lung function in 40s even after 3 years of her going on this medication. Remember, this is the girl who had significant bronchitis, significant lung damage, and in that girl, we were able to reverse the lung damage so significantly that this girl came off CPAP, oxygen, and was able to show an improvement of lung function by almost 100%. So my point is that this is a wonder drug which has changed the life of CF patients significantly, and this has been in the market for almost 12 years now. So this is the first among the CFTR modulators which came to the market. But the downside was that this was only eligible for 9 CFTR mutation, and this account only for almost less than 2% of CF population at that time. I'm just going to skip because I don't have time to go through this detail. Now, Initially, when it was available in the market, it was only available for 9 CFTR mutations. But subsequently, it was licensed for fewer mutations, and this is the list of mutations which ivacaftor is eligible to be used now. Now, the dosage, again, when we started using this drug, this was only licensed from 12 plus age 2. But in the last 10 years, the age at which we can start using ivacaftor has come down to almost 4 months now. So nowadays, if they have the right mutation, we are able to start this drug from 4 months of age. As you can see, at 4 months of age, we put them on granules. And as they grow older, we put them on capsules. By the time they reach 6 years, we can change them from granules to capsules. So we have some difficulty when you start with granules first, but then from 6 years, we can put them on capsules. It's very simple. Twice daily, they have to take this medication. That's all. And one of the difficulties which we found in our practice is that when we first introduced this medication, people took this medicine like any other drug, i.e. they were not bothered about the compliance. They take the medication for a few weeks and they hardly use it. And we had some real difficulties in convincing the family that this is a very expensive drug, please use it. So it took us a while to convince the family that it's not like another drug which you use. It's an expensive drug, very effective drug, but once the patients saw the difference for themselves, they became much more compliant with it. And recently, when we checked our compliance, when we looked at the prescription they collect from a hospital, we think almost 94% is the compliance of our CF patients to this drug. Compare this to any other drug, which we'll be lucky if we can get more than 50%. So to this particular drug, there's a good compliance because patients know that there's an effective drug. If you ask me, most of my CF patients who take this drug, I think they're only taking this one drug, and they might take chronic insufficient. They won't be bothered about other drugs. But these two drugs they take religiously because they know it makes a big difference in them. So this is the dosage based on the age. The second one of the CFTR modulators which came to the market is Orkambi, which was eligible, which was licensed for the most common CFTR mutation, which is delta F508, which accounts for almost 52% of CF patients worldwide. Approximately 80,000 is the CF population worldwide, so almost 40,000 patients will benefit from this particular drug. But unfortunately, the effect of lung function with this particular CFTR modulator was less compared to ivacaftor. For example, in the trial, improvement of FEV1 was about 8% with Orkambi compared to 9% for ivacaftor. But if you ask any CF clinician, they will say, the ivacaftor is a much better drug compared to Orkambi. But still, it made a big difference. So Orkambi was the second drug which came to the market in the CFTR modulator. Then we had a couple of other drugs which I'm not going to go through because they were not that effective. And again, the age at which we can start Orkambi has come down significantly, 2 years now compared to 6 years when it was started. But the bottom line is that we have got medications now which we can start from a very young age, which make a big difference in the CFTR and in the CF management. And finally, the best of the lot, Trikafta, easily the best of all the CFTR modulators. Even in the trial, they showed an improvement of almost 12%, and practically, we are seeing much better improvement than 12%. Now, I'll tell you one interesting story happened about a year back. One of the CF girls I used to look after in Manchester, she's a teenager now, and she had a very bad clubbing, that I knew from the beginning. And, teenage girls, they don't clubbing, and she was always upset about this clubbing. She always used to tell me, why is it happening to me, Dr. Why reverse this? She went on Trikafta. In 3 months, her clubbing reversed, and she sent me a photo. It's still in my Facebook Messenger. She sent me a photo showing the difference in her clubbing within 3 months of her going on Trikafta. It's a wonder drug. Believe me, it's a wonder drug. It makes big difference in the overall quality of life, their life, plus even simple things like clubbing, which is a big thing for a teenage girl. It's the newest of all the lot. Now, the good thing is that we are slowly, basically, this is licensed for delta F508, the most common in CFTR. We are slowly changing most of our patients to Trikafta now, because even the patients who are taking ivacaftor, we are on Trikafta now. Now, the most difficult thing with this drug is the cost involved. Basically, initially when it came out of the market, it was about $350,000 per year per patient lifelong. So you can work out how much it's going to cost. And here in UAE, it was about just about $1 million dirham per year. The cost has come down, but not by much. I think it's about 750 to 800,000 per patient per year is the cost of most of this drug now. And that's the difficulty. It's a very expensive drug. Finally, in the last 3 years, there are two companies which is making generic version of ivacaftor. Remember, ivacaftor is 12 years now. They're coming out of patency now. And in Oman, I know they have almost 100 patients who is taking a generic version of ivacaftor now. So with the generic version, price is significantly less, but still quite high, about 400,000, I believe. High priced. But the downside of this is the cost of this drug. But I'm certain that within a couple of years, ivacaftor, since it's coming out of patency, we will be able to get a cheaper version. And I think the pharmaceutical company which makes ivacaftor lower the price of ivacaftor. They will try the best to change the price. So they will definitely bring the price of the first one. And I hope all the patients across the world will be able to benefit from this drug. But believe me, if you ask me, I think the CF babies who are born now will live at least 20 years more than the ones who were born in the last decade. So this is a wonder. And if I remember correctly, this was voted as the best breakthrough in clinical medicine in the last decade. It's such a wonderful drug. It has changed significantly the quality of life of the CF patients. The only one thing we need to be careful is when we start them on this drug, we need to monitor the liver enzyme level quite religiously. Sometimes they can have deranged liver enzyme, and if that is the case, we need to adjust the dose. That's very important. And also, the insurance company will insist on getting the sweat test checked regularly to make sure they're taking the medication, because once you start the medicine, within 2 to 3 months, the sweat chloride will normalize. So they will look at sweat chloride to see if the child is taking the medication or not. So based on the requirement of demand, we need to check the sweat chloride quite regularly and regularly monitor the liver enzyme level to make sure there is no side effect with this. So I don't have much time. So to summarize, there are 3 main CFT modulators which we use now. The latest of the one, Trikafta, is the best among the lot, which has made significant improvement in the quality of life, and I'm sure life expectancy of all the CF patients across the world. Thank you.
Thank you very much, Dr. Jaya. Thank you. Any questions? In fact, we cover almost 100% of Omanis with both ivacaftor and Orkambi in our patient, and we